There are at least 3 well-recognized chemotherapy regimes which are used as radiation sensitizers. The mild is weekly carboplatin and paclitaxel, which is predominantly reserved for very frail patients. The worry is that the systemic dose is relatively small, and given that the function of the chemotherapy is partly to make the radiotherapy more effective, but also to have an effect on hidden metastatic disease, that's a worry. I think for that reason, the so-called SWOG regime of day 1 and day 8 cisplatin and days 1 through 5 etoposide on a 28-day cycle is probably most commonly used for everyone except the very frail patients. In recent years, CALGB did show that full-dose carboplatin and pemetrexed was about the same in terms of equivalence, maybe a slightly higher rate of pneumonitis. And I still use that, but I only use that for patients that I know have a gene rearrangement. And that comes from a large amount of data that the gene rearrangement diseases, ALK, ROS1, RET, even NTRK, are particularly sensitive to pemetrexed. So only in those patients am I using a pemetrexed-based regime. Using EGFR inhibitors in chemoradiotherapy, I would say has almost no role. It doesn't work for somebody who doesn't have an EGFR mutation. If you had an EGFR mutation, there is a clinical trial going on to see whether induction, maybe of 6 weeks of EGFR-TKI, could make the treatment more effective when you then go on to standard chemoradiotherapy. But I see no role for combining it together.